This is Dr. Eric Kandel. As you know, he is a Nobel laureate, a professor at Columbia University, and a Howard Hughes medical investigator. I am pleased once again to have him here to help me understand all about the brain. So welcome back.
Thank you. You're doing very well understanding the brain.
And what a journey it is. So tell me about today, the disordered brain.
Well, last time we discussed psychiatric disorders. Today we're going to discuss neurological disorders. These are both disorders of the brain. So one of the first things we want to explore is how do they differ from one another? What's the logic of neurological as compared to psychiatric disorders? Now there are two fundamental differences. One in the nature of the symptoms and two in anatomical location. In terms of symptoms, there is overlap. But from a simplified point of view, you could say that psychiatric disorders deal with enhancements, exaggerations of our everyday life. We all feel despondent periodically. We all feel hopeless and worthless when an experiment doesn't work. And this is an extension of what you see in depressed people. The mirror image, euphoria, we experience when things go well, when we have a wonderful roundtable discussion. And we see a dramatic extension of that in manic disorders. And even schizophrenia, the hallucinations and delusions, we have examples of that in our dreams. By contrast, neurology differs in two ways in terms of symptomatology. First, we see fragmentations of symptoms. In Parkinson's disease, we see a dramatic slowing of movement. But in addition, we see the appearance of behaviors that you don't normally see otherwise. With a lesion of the parietal lobe, we see neglect of a whole side of the body. Just absolutely remarkable, a denial that it's there. But perhaps an even more fundamental distinction is anatomical. We know very little about the anatomical location of psychiatric disorders. What are the brain regions that are involved in schizophrenia and depression? We're just beginning to explore that. With neurology, we have an amazing understanding of the neurological underpinning of neurological diseases. And we've known this for years. When I was a medical student in the 1950s, clinical neurology was known as the medical discipline that could diagnose everything and treat nothing. This has changed dramatically. As we're going to learn in this program, there are major new treatments coming along in neurology that have revolutionized treatments in various neurological disorders, Parkinson's disease, stroke, even spinal cord transections. Now, one of the interesting things about it, this progress again has involved finding out more about the location of specific neurological diseases. It's location, location, location that counts in the brain. And the history of how we localize functions itself is so fascinating. It began around 1860 with Paul Broca. Paul Broca was interested in disorders of language, the aphasias, and much of what we learned about the early localization of functions came from studies of language disorders. Broca encountered a very interesting patient one day. He had an aphasia, a language difficulty, which took the form of the fact that the patient could not express himself very satisfactorily in language. He could understand language perfectly well, but he couldn't make himself understood. This was not simply a paralysis of the vocal cords. He could hum perfectly well. Moreover, he couldn't write language. He just could not express himself in language. When he died...
But he could understand.
He could understand perfectly well. When he died and came to autopsy, Broca examined him and found a lesion in the front of the brain. He wanted to talk about this to his colleagues, so he had to give it a name, and in all modesty, he named it after himself, Broca's area. He then encountered 8 other patients that had a similar aphasia. They could not express themselves in language, but could understand perfectly well. When they died and came to autopsy, he found invariably they had a lesion in the front of the brain, and invariably the lesion was in the left side. And this caused him to realize one of the major insights we have in the biology of the brain. We speak, he said, with our left hemisphere. The left hemisphere is specialized for speech. This galvanized the scientific community. People began to look for other localizations of functions. And 10 years later, Fritz and Hitzig, 2 German investigators, working on dogs, found that there is a systematic representation of body movements in the surface of the brain called the motor cortex, or the motor strip. If you stimulate one part of the motor strip, your face moves. You stimulate another, your arm moves. Stimulate another, the leg moves. So there's a systematic representation of your body movement on the surface of the brain. This is extraordinarily exciting. And a few years later, in about 1875, another giant came on the scene, Carl Wernicke, an extraordinary guy. A couple of years out of medical school, before he was 30 years old, he made a fantastic discovery. He found another language deficit, another aphasia, but this was a difficulty in understanding language, not in expressing it. So this patient could express language perfectly well, but he couldn't understand language. When he came to autopsy, Wernicke examined him and found a lesion not in the front of the brain, but in the back of the brain.
But the left hemisphere in the back.
In the left hemisphere, but in the back. So again, he had to name it so he could speak to other people about it, and he called this Wernicke's area.
Right.
And he said to himself, isn't it interesting? We're dealing with a complex function like language. This is not localized to a single region. This involves at least two regions, one for understanding language and one for expressing it, like a sensory area and a motor area. And when he looked to see where they were located, he realized that the Wernicke area, the area he had worked on, was at the back of the brain. This is where sensory information comes in. So when
understanding is where the sensory information comes in.
Exactly. So information from reading or hearing feeds in from the back of the brain into the auditory cortex and the visual cortex. These two areas converge onto Wernicke's areas and put that visual information and auditory information in a code for understanding language. He also knew there was a connecting pathway called the arcuate fasciculus that went from Wernicke's area to Broca's area. So the information goes from the sensory areas to Wernicke's area, from Wernicke's area through the arcuate fasciculus to Broca's area.
Now, what kind of connection is that?
This is a pathway, an
Just
anatomical pathway. Right. And that question that you raised made him realize a very profound thing. He said, I bet you one can get an aphasia, a language deficit, without damaging Broca's area or Wernicke's area by simply interrupting the pathway. You got it. You're a functioning neurologist. Interrupting the pathway between the two. Under those circumstances, the patient understands, the patient can speak, but there's no connection between the two. It's like an occasional presidential press conference. Information comes in, information comes out, but there need not be